Welcome to the lecture for psychopathology. We'll be talking a little bit about personality disorders. So before we can talk about personality disorders, we can talk a little bit about what normal personality is, right? Before we think about how it can be disordered. So what is personality? Well, a good general definition is it entails your consistent behavior patterns and intrapersonal processes, right? So behavior patterns are pretty easy to understand, right? So it's how you act, right? The way you are. The idea that you have these patterns of behavior such that you typically act the same way in different situations, right? So when you go to a party, do you typically introduce yourself to people, or do you more sit back and not talk to people, right? What are the typical behaviors you display? So those would be some behaviors, but your personality would be all of the behaviors that you exhibit that are consistent, right? And then intrapersonal processes, maybe a little less clear what that is. What's going on inside of you, so thoughts and feelings that are consistent, right? So again, when you go to that party, if you see somebody across from you that you think it might be interesting to talk to them, not necessarily what you do, that's your behavior, but what you think and what you feel. Do you feel anxious about approaching someone and talking to them? Do you feel confident, comfortable? You know, what are your thoughts? You know, are you thinking that they're gonna judge you negatively or positively, or that you have no preconceived beliefs about how they're gonna think about you, right? But the idea that you typically have some way of thinking and feeling across situations in response to certain stimuli, right? And not that you'll always be the same way, right? I talk about people being extroverted or introverted. People who maybe are considered introverted, right, who tend to be less seeking of novelty, more shy, more predisposed to spending time with their own thoughts, might on occasion be the life of the party, right, given certain environmental circumstances being present. But overall, they have a tendency to not be, right? So personality isn't, okay, you have this is your personality, you always are this way. No, it has to do with tendencies, and that you'll probably be this way in most situations across most time periods. In terms of understanding exactly what personality is, several different theories that it could be viewed from. One of the earliest ones would be Freudian theory, obviously talking about the self, the identity being made up of three components: the id, the ego, and the superego, right? Where the id is the source of all those impulses, and depending on what stage of Freud's career you're reading, looking at aggression or looking at sex or both. But the id wants stuff, and following the pleasure principle, it has needs, it has these drives that it wants to feel good and not feel bad, and it wants it immediately. Right? And then you have the superego, which is kind of this internalized parent in culture and society that tells you, no, the things you want are bad, right? And then you have the ego, which is the middle person who tries to satisfy the wants of the id with the prohibitions of the superego, and then also while dealing with the limitations and opportunities of reality. Right? And Freud said, you know, the way that you consistently act has to do with the interactions between those three aspects of yourself, right? And often talking about defense mechanisms, which are strategies that you come up with, the ego comes up with, to deal with the conflicts generated by the ego, the id and the superego, right? To defend against anxiety caused by wanting things that some party is telling you shouldn't want. So you develop these defense mechanisms like denial. Right? And that those defense mechanisms are really what make people different or unique from each other, and therefore that would be personality, right? Because personality, usually, when we talk about it, we're always talking about individual differences. How is this person different from this person? How is this person's personality different than this person's personality? And then you have a multitude of neo-Freudian theories that often accepted some core structure of the mind akin to Freud's, with the id, the ego, and superego, but then vastly different points of emphasis, usually deviating from the focus on the id and the superego, and really most of the neo-Freudian theories focusing more on the the ego itself, and that part of itself that's trying to make those accommodations. You have your Adlerians, your Jungs, your Karen Horney, all these different theorists which emphasize different parts of personality, and probably none of the Neo-Freudians really put forth a complete theory of personality, that can be argued, but they all focus on different aspects of personality and came up with theories to try to predict and explain behavior. And then you also have behavioral theories, which say, well, all that stuff you Freudians and Neo-Freudians are talking about is a bunch of hooey, because you can't observe it. All we can observe is behavior, and all we can look at is consistencies in behavior, and we can understand those using behavioral theory, which is usually, when you say that, usually you're talking about learning theory, right? So classical conditioning, operant conditioning, so that people are the way they are because of really the environment, because they've been rewarded for being that way, and they've been punished when they've tried to be other ways. So all our behaviors that we call personality are really just outcomes from combinations of rewards and punishments. And then you have cognitive theories, which are often similar to behavior theories in terms of looking at the importance of learning. But then they also take into account, obviously, this other variable, which is cognition, that is not just reward and punishment, but how you think about reward and punishment, and looking at how people evaluate inputs, stimuli in the environment when choosing how to be. Right, so when going to that party and deciding what behavior to exhibit, people don't just react like a dog to the dog food salivating. That it's not this reflex behavior, but people think about themselves. So looking at self-concept, self-efficacy, all those things, which a lot of cognitive theories of personality add that component to personality theory, but again, not a complete theory usually. And then really the family of theories that hold sway today, and it's not one theory, but more of an approach would be trait theory, or a trait approach to personality, which is in some ways atheoretical in terms of it's not Freudian or behavioral or cognitive. So it's not theoretical that way, but it is theoretical in other ways. But basically, trait theory says that regardless of how you get to be this way, right? So there's no explanatory mechanism in trait theory from trait approach. All the trait theory says is we can talk about how you are in terms of a couple of traits that are fairly independent. Right? So instead of having to look at every single behavior, there are groups of behaviors and thoughts and feelings that cluster together, such that whenever you are maybe talking to people a lot at parties, and people say, "Hey, free bungee jumping lessons." You're like, "Yeah, that sounds good to me." People say, "Hey, do you want to play this game or read this book?" "Hey, I want to play this game." All those behaviors together, people who would say yes to one of those would most likely say yes to all of those things, because they all reflect some common trait, like extroversion, and then we can divide up into a finite number of traits and a fairly small number of traits, according to some people, the number of ways that people are different from and similar to each other, right? And that people vary from each other, not in terms of, okay, you are this way or this way, you're this trait or you're this trait, right? It's not in terms of personality types, but everybody is somewhere on all the traits. So each trait has a level, a degree of traitedness, right? So how extroverted are you, or how not extroverted, which you could conceivably say introverted as the opposite of extroversion, obviously. But that we all differ in terms of the levels of certain traits that we display. And that's probably the predominant theory right now. But disagreements continue. And again, when I say trait theory, again, it's not a theory, it's an approach, because there are a couple different trait theorists that they disagree about which traits are the traits that all people exhibit, right? And how many traits there are. There's general consensus lately towards 5 traits. But other people say, no, I think 7 is a better explanation. Some people still say, 16 is a more accurate number, fits reality better. And they continue to disagree about how many. And even if they agree on how many there are, maybe if we agree on 5, what are the 5 traits that people differ on? There's still disagreement. which is important when we think about, okay, we're trying to talk about pathological personality, disorders of personality. And how confident can we be in saying, okay, the way this person's personality is, the way they consistently behave, is pathological, if we can't yet fully agree on what is normal, right? So like for depression, we can generally agree, okay, there's this range of mood that most people say, okay, yeah, if you're in this sad is okay, you get too much more sad, yeah, it's pretty clear that's something different, right? So we can come up with some level of agreement about what's normal in terms of how good you should feel versus how bad or how happy. More difficult when we get to things like personality. It's going to be more nebulous. Okay? So keep that in mind as we start talking about personality disorders. Okay. So when we so now it's important to think about the definition of a personality disorder. Now we've talked about what personality is. So according to the DSM, it's an enduring pattern of inner experience and behavior, right? Which is similar to what I told you before for normal personality, right? Consistent behavior patterns and intrapersonal processes, right? Inner experience, how you think and how you feel, and then behavior, what other people can observe that you do. It's a pattern, so it's not one thing. It's not you do one thing one time. You do that. You are that way repeatedly, right? And it's enduring. It's not for some while. Like if the Cowboys could ever win a football game, and you get really excited and start yelling and screaming, that's not your personality. You're not yelling and screaming all the time. So it's more of how you are regularly for a while, right? But again, so that's kind of the personality part. And we start getting to the disorder part that deviates markedly from the expectations of the individual's culture. Okay. And this it's supposed to be the individual's culture, the client's culture, right? Unfortunately, what sometimes happens in clinical practice is when making a decision, okay, is this pathology or not? The decision that gets made is, does it deviate from the clinician's culture, right? My patients, because if I don't know that other people have other have these other cultures have different expectations and what might be normal for them, if I'm not familiar with that, if I'm not willing to explore that, be open to that, then I'm more likely to just impose my own culture assumptions and say, okay, well, wow, you shouldn't be that shy, or you shouldn't be that outgoing. Something's wrong about that, right? And it may or may not be for that person in their culture. And you're tasked to figure out what their culture is. Unfortunately, many clinicians don't do that, and they just, again, impose their own culture. But you don't do that. Okay. It's pervasive and inflexible. So this pattern is pervasive and inflexible. So again, it's not pervasive. It's not just they're this way at work or they're this way at home. They're whatever this way is. They have this pattern of behavior that is kind of deviant in terms of other people aren't like this across settings. And then the inflexible part, which talking to one of the big personality researchers is one of the things that he tried to I think really imprint on me, is that this inflexibility is central to the definition of personality disorders. That we all have ways of being that fit, that work for us better in some situations than others, but most of us are able to adapt somewhat, right? So if you're a shy person, but you're going out on a job interview, you make yourself be more outgoing, right? You push yourself. It's not easy, not comfortable, but you do it to get the job, right? Or maybe you're kind of a messy person who has a cluttered desk everywhere, but then you're going out on a first date and you clean out your car and you get everything nice and organized and neat, right? Because you're trying to present some a certain appearance persona. So you can be different whenever you feel the pressure to. The idea with people with personality disorders is that they can't, even whenever it would benefit them, they would be rewarded for changing. They have a hard time. Not impossible, but they have a harder time changing how they are. There's an inflexibility about their behavior and inner experience. Right? Okay. It has an onset in adolescence or early adulthood. Right. So the idea here is that this is really how people's personalities are, not just reactions to life, but that the idea that these disorders are formed early on, just like we consider personality to be formed early on. When again thinking about normal personality, we expect from a trait approach, people to move on those traits. Especially in childhood, adolescence. Somebody may look pretty extroverted now, a few years later, not so much. But then around in your 30s, whenever we start seeing more stability in groups of people in terms of those trait measures, where people, you're this high on openness to experience, and in 10 years we can expect you to be similarly high or low. Right? But until you get to about 30, we expect some movement. Right? So same thing with personality disorders. Just because an adolescent looks like maybe they have borderline personality disorder, they have an unstable sense of self, their mood's all over the place. Oh, it's adolescence, and we expect them to possibly look a little bit pathological, but we say, it's not set yet. We expect it could change, so it's not a personality disorder. But it might start. We might start seeing those things in adolescence, early adulthood, but we really don't tend to diagnose them until adulthood. They're stable over time, which again is another reason why you don't typically diagnose them in young people, because you usually don't have enough time yet to know that it's stable. And then it leads to distress or impairment, and more frequently it will lead to impairment than distress for a lot of the personality disorders, because people are like, hey, this is how I am, just because the world's a bunch of idiots that don't know the way things should be. Why does that make me have a disorder? Right? So it doesn't bother them to be how they are, often, but it may lead to impairment, and it must lead to one of those to merit diagnosis. Okay, some questions to keep in mind as you're thinking about personality disorders is personality and personality disorders in particular better thought of as categorical or dimensional? So we're talking about, are there different kinds of people? So, okay, you're narcissistic, you're dependent, you're histrionic, you are this way, or is it more a matter of degree, such that everybody is more or less narcissistic and more or less histrionic and more or less dependent? So the research says it's dimensional. And I can say that because, without getting into too much detail, looking at the kind of fancy taxometric studies and factor analysis and stuff, that there aren't these clearly different groups of people, such that there's these narcissistic people and these histrionic people, and they're completely different on measures of personality, and there's this huge separation. No, one group is usually higher on some things than others, but there's a lot of overlap. And then there are people between two, there aren't just two extremes. There are people all in between the two extremes. So the personality appears to occur on a continuum, and personality disorder traits, behaviors, symptoms also appear to occur on a continuum. Nonetheless, it is looked at and thought of as categorical by many. It's categorical currently in the DSM-4. May change with DSM-5. We'll still wait and see. But again, important to keep that in mind. Even if somebody has this diagnosis, okay, well, this person has narcissistic personality disorder. Again, it doesn't mean that they're necessarily qualitatively different than somebody else who doesn't have that. They're probably just higher on some measures of narcissistic traits. Okay. Another question is, are the personality disorders, do they have gender bias? And two different types of gender bias. One would be criterion gender bias. And this is the idea that the disorder reflects a stereotype of one gender, but not the other. And often you hear this talked about with histrionic personality disorder, that it's kind of this hyper-femininity, seeking of attention and some dependency on others, and emotionality, which are thought to be more feminine traits. That is kind of, there's a pathological label for that. But if you think about the opposite of the masculine opposite of some of those traits, about being very unemotional and cold and distant, there's not really a hyper-masculine personality disorder. Why is that? One reason may be because it was largely men who voted on these categories, these labels to be put into a book that makes up our diagnostic system. Right? So debate goes on about whether or not criterion gender bias exists, and different lines of evidence used to say yes it does or no it doesn't. And then even if there isn't criterion gender bias, there's also the possibility of assessment gender bias. And this is where sometimes the same behaviors that a person engages in, exhibits, might be viewed differently if they're male or female, such that a female exhibiting certain behaviors might get a label. A male exhibiting those same behaviors might not get that same label, might get no label at all, or might get a different label. And there is some evidence for that, where, easy to do those studies where you write up a description of somebody's behavior, and on half of the and you make a bunch of copies, right? Half of the copies you put, this is Joe, and the other half you put Joanne. You send out these papers to a bunch of therapists, and you have them diagnose them, and you get them back and say, okay, with the same behaviors, does Joe get the same diagnosis as Joanne? And frequently the answer is no. And people will look for what we think of as stereotypically feminine disorders in women, and they'll look for stereotypically masculine disorders in men. So one thing you may see is if you get a certain story down, you may see the same story being diagnosed as borderline personality disorder if it was said to be a woman, and antisocial personality disorder if it was said to be a man. So some evidence of gender bias. Again, that evidence isn't fully consistent. Not all studies find that when looking at the same question. So depends on who you're asking to do the ratings. Another thing to keep in mind are the high rates of comorbidity with personality disorders, and not so much, to some degree, personality disorders with Axis 1 disorders. Remember, personality disorders are Axis 2. But even more so, personality disorders with each other. And if you get diagnosed with one personality disorder, you're at a pretty high rate of getting diagnosed with a second. And once you have a second, you're at a pretty high rate of getting diagnosed with a third. And so the question is, well, if we have these high rates of comorbidity, well, I got that out of order. There it is. Does this really reflect different problems? Do people really have these two problems, or is it one problem, one kind of pathological personality cluster that's manifesting in a way such that they happen to meet criteria for two different labels, but really it's one problem, right? Because if it's two problems, you could treat one and the other wouldn't go away. And that doesn't seem to be the case. We can't influence one diagnosis without influencing the other. So it seems to be really one thing that happens to be meeting two criteria. Why might that be? Well, probably because we have some poor diagnostic criteria and a lot of overlap between and among diagnoses, such that one behavior can be diagnostic of, can be a symptom of two different disorders. And that's a problem, logically, diagnostically. So some of the high comorbidity may be not so much because people have all these problems, but just because the categories are poorly defined and they just really have one problem. In terms of the course of personality disorders, again, by definition, they're stable. Right? So, and they generally tend to be fairly unresponsive to treatment, more difficult to treat than most Axis 1 disorders. That being said, if we look longitudinally, kind of over a long period of time, people usually continue to meet criteria, and even if they don't, they show symptoms. But the severity of the symptoms and the number of symptoms does seem to decrease with age. Which again shouldn't be that surprising when we look back over at the normal personality research, because people become less extreme on their different personality traits over time as well, right? For people with normal personalities. If you're super extroverted, super introverted as a young adult, but when we look into older adulthood, you'll probably still be on whichever side of the middle you were on before, but you'll be closer to the middle, right? Same thing with personality disorders. Less extreme. Why might that be? However you are, whatever your personality is, It does not exist in a vacuum. You're out there interacting with people in the world. And when you have people in the world, you're getting feedback. And again, people without personality disorders generally pretty good at, well, they vary in how good they are at reading, receiving, and responding to that feedback. People with personality disorders usually not that good at it. Even if they're not that good, over a long enough period of time, they're going to tone some things down. So society kind of wears down the rough edges of all our personalities, and for people with personality disorders as well as those without personality disorders. Okay. So now if we look at specifically the criteria for personality disorders, which is very similar to the definition. So we have that, the pervasive pattern of, and just like we said before, pattern of inner experience and behavior, yada yada, beginning by early adulthood and present in a variety of contexts, as indicated by, and then 4 or more, 3 or 4, 5, 6, depending on the diagnosis, and different diagnoses have different numbers. I don't care if you memorize them, but just know that some amount of symptoms are required, right? And the symptoms differ across disorders. And then the other criteria that's in there is does not occur exclusively during the course of, basically some other disorder, right? So if somebody, we'll talk about schizotypal personality disorder, right, which has these odd beliefs or magical thinking, paranoid ideation, odd appearance. If you meet criteria for schizophrenia, and schizophrenia explains your odd beliefs and your unusual perceptual experiences and your odd thinking, well, you don't get schizotypal as well. It's better explained by this other axis 1 disorder, right? Now, one thing that it's not in the criteria, but in the DSM elsewhere, when just talking about personality disorders, is they say that the pattern deviates from expectations of the individual's culture, right? Which again is what I said in that definition earlier. But it's one of those things that it's in the DSM, but I think since it's not explicitly in the criteria, that sometimes gets ignored. All right, so when we look at the personality disorders, they're in the DSM, they're divided into 3 clusters, with the thinking being, okay, that the ones in cluster A are kind of similar to each other, cluster B are similar to each other, and cluster C, they're all similar to each other. Which, standing back, looking big picture, yeah, generally, but there's sometimes you'll see some things within a cluster don't fit as well with each other as maybe they should, and you'll see sometimes where, well, this cluster A, this one that's in cluster A, and this one that's in cluster B, they often co-occur, and they seem pretty similar. They should be in the same cluster. But we have what we have. So for now, we'll talk about the cluster A personality disorders, which by and large are characterized by individuals who may appear odd or eccentric. Right? In terms of prevalence rates, paranoid personality disorder, between 0.5 to 2.5% of the general population. Schizotypal, around 3%. And then schizoid, pretty rare, less than 1%, and rarely seen in the clinic. Excuse me. Okay. For paranoid personality disorder, characterized by pervasive distrust and suspiciousness of others, such that their motives are interpreted as malevolent, as indicated by 4 of the following. So 4 symptoms, right? But basically, suspicious. And people's motives are interpreted as malevolent. So somebody bumps into you on the bus. If you have paranoid personality disorder, it's not just that, oh, the government's out to get me, but somebody bumps into you, you think they meant to do that. Right? So it doesn't have to be this fully conceptualized paranoid ideation with this whole people are out to get me and there's this plot, but it's this tendency to think that people are jerks and doing stuff to be mean to you, right? And that they will betray you. So criteria that suspects without sufficient basis that others are exploiting, harming, or deceiving him or her, which again, somebody may be frequently exploited, harmed, and deceived. So to diagnose this, you've to accurate diagnosis, I should say, you should really figure out, are they paranoid? Are people really exploiting them? If they're in a relationship with somebody who's exploitative and maybe kind of narcissistic personality disorder, antisocial personality disorder, they may be being exploited and harmed, and somebody really is out to get them. So you should do your due diligence and figure that out. Preoccupied with unjustified doubts about loyalty or trustworthiness of friends. And again, how do you know if they're justified or not? Unless you interview their friends, which we don't usually do. Reads hidden, demeaning, or threatening meanings into benign remarks or events. So again, somebody says, nice day, isn't it? Huh, nice day. So you're trying to say that it's nice now, but it won't be soon because you're going to do something, right? So people say innocuous, benign things, and then saying something either threatening or demeaning. They're talking down to you. Oh, you think it must be nice for me to be out and because I'm not in jail right now, huh? I should be in jail. Is that what you're saying? Right. Persistently bears grudges, which at first glance you might think, well, if you're paranoid, what does that have to do with bearing grudges? Well, think about it some more. If people are out to get you, and you think somebody has wronged you, if you were really paranoid, would you go, yeah, they screwed me over once, but it probably won't happen again? No, yeah, you would hold a grudge. You would go, yeah, I'm gonna get them. I can't ever forgive them for that. Why can't you forgive them? Because they can't be trusted, right? So it's just a reflection of the other core aspects of the paranoia. Perceives attacks on his or her character that aren't apparent to others, and is quick to react angrily, and has recurrent suspicions, again, without justification, which you should figure out, regarding the fidelity of a partner. Which again, if the partner is really cheating on them, is it justified? Yeah. So can you have paranoid personality disorder if the person is in a relationship with somebody who's cheating and has shady friends? It gets more difficult, but if you have the other criteria, you can still figure that out. Okay. Schizotypal personality disorder. Pervasive pattern of interpersonal deficits marked by acute discomfort with and reduced capacity for close relationships, as well as by cognitive or perceptual distortions and eccentricities of behavior, is indicated by 5 of the following. So you have 3 things there, right? The first one, interpersonal deficits. So discomfort and reduced capacity for close relationships. So they don't do well around other people. They're not comfortable with it. They feel anxious, uncomfortable, want to jump out of their skin being around people, and they're not good at being around people. Socially awkward. Socially awkward and uncomfortable in close relationships. And this isn't just at a party they're uncomfortable, which they probably would be, but just one-on-one in close relationships, still not able to deal with that those interpersonal interchanges. Right? And you also have cognitive perceptual distortions. And we think about perceptual distortion, we think about kind of hallucinations, delusions, that type of thing, right? And thinking oddly, right? And then eccentricities of behavior, so behaving oddly. So sometimes ideas of reference that aren't delusional. So ideas of reference, that's whenever you think that random events are about you that are in reference to you, right? Yeah, it rained yesterday because I was really sad. But if you say, really? You think it rained because you were sad? Nah, probably not really, but it kind of felt that way. Right? So it's not, yes, definitely, it always rains when I'm sad. If they say that, okay, now that's kind of getting to delusional intensity, and so it's possibly delusional disorder or schizophrenia. So they have these ideas of reference that things are about them, but if you push them on it, they don't believe it real strongly, where they're willing to fight you on it. Odd beliefs or magical thinking that influences behavior and is inconsistent with subcultural norms. So magical thinking, thinking that they have a sixth sense. I knew that was going to happen, right? Or even bizarre fantasies can be included in this criteria. But again, you have to say it's inconsistent with subcultural norms, not just cultural norms, but subcultural norms. So if they're into, they're kind of a Harry Potter geek, right? And they are talking about magic. That may or may not qualify for this symptom. If their group kind of talks about those things, and it's normal for them, it may not be a symptom, right? Or if you think about the evil eye. If somebody looks at your watch, so that's a nice watch, and you say, well, now I got to give it to you, or something bad's going to happen to me. Well, that's kind of a strange thought. Well, in some cultural groups, that's culturally appropriate, and the kind of mal de ojo. You don't. If somebody looks at your stuff and notices it, that's bad luck. Now you got to get rid of it. So again, you have to be culturally sensitive to figure out what is magical thinking and what's not. Right? Unusual perceptual experiences, including bodily illusions. Feeling like someone else is in the room would be an unusual perceptual experience. So they don't see something or hear something, but it feels like someone's here. Right? Or bodily illusions, feeling like a part of their body isn't their own. Oh, that's not my finger. It's not moving. Again, if you kind of push them on it, it's usually not the same degree of odd thinking as you'd see in schizophrenia, but it's close. It's kind of on this continuum, right? Just generally odd thinking in speech, which is hard to define, but easy to recognize. If somebody's talking to you and they have kind of odd thinking in speech, you go, "Oh, wow, that's odd thinking in speech." Suspiciousness or paranoid ideation, which you go, wait a minute, we just talked about paranoid. It's paranoid personality disorder. Was it in this thing too? Yeah, exactly. We have overlapping criterion sets, right? So fairly high rates of comorbidity with paranoid personality disorder and schizotypal personality disorder. And part of that because they share a symptom, right? Inappropriate or constricted affect. So constricted affect, they don't show a lot of emotion. Inappropriate, they laugh at sad things, cry at funny things. Which again, you would imagine would contribute to their discomfort with close relationships if they're having inappropriate affect. Behavior or appearance that is odd, wearing a full Jedi costume, not to a convention, but just to go to the mall. That'd be something that might be a little odd. Lack of close confidants other than first-degree relatives. So they may have some close relationships if it's their mom or a brother or sister who's been around them long enough and they can feel comfortable with them. But other than that, not really. And then excessive social anxiety that doesn't diminish with familiarity and tends to be associated with paranoid fears. So again, not just somebody who's shy and then warms up after a while. They continue to be socially anxious even after they get to know you. And usually because it's related to the paranoia and thinking that you're out to get them. And then the third disorder in cluster A would be schizoid personality disorder, characterized by a pervasive pattern of detachment from social relationships and a restricted range of expression of emotions in interpersonal settings, as indicated by 4 of the following. Okay. So again, if we go back to schizotypal, we had interpersonal deficits, and schizoid is detachment from social relationships, and also restricted range of emotions, which again in schizotypal, one of the symptoms was constricted affect, which is the same thing as restricted range of expression. So some overlap in symptoms there between the two, but they're pretty different, and you usually don't confuse the two of those, even though you have some overlap, which is interesting. So these individuals neither desire nor enjoy close relationships, theoretically. Almost always the individual chooses solitary activities. Hey, you want to come play chess with this person or do this thing, or do you want to read a book by yourself? I'm going to read a book. Right. Has little, if any, interest in sexual experience with another person. So they might, it's not that they're necessarily devoid of sexual feeling. They might masturbate regularly, but no interest in doing it with someone else. Takes pleasure in few activities, kind of 1 or 2 things they like to do, and they stick to that lack close confidants other than first-degree relatives, which again overlap with schizotypal. Appears indifferent to the praise or criticism of others, which will be important. It shows an emotional coldness, detachment, or flattened affect. So these people that are very kind of flat, and it's really about, seems to be about interpersonal, and not about, with schizotypal we have those that are kind of odd thinking, this kind of perceptual disturbances, this kind of oddness, right? Schizoid isn't that oddness, it's just not people. Don't want to be around people, which you may think, well, that sounds kind of like autistic spectrum stuff, which, yeah, it does, but not a lot of confusion and diagnosis in terms of present a case, and people generally do a good job of distinguishing. Okay, we all agree this is schizoid, and we all agree this is autism, and not much confusion about that. I guess, which is, looking on the face of it on paper, it looks very similar, but experientially, qualitatively, phenomenologically, different enough that you can kind of tell that there is this difference. Right. And because it's rare, it's probably not the best understood personality disorder. And one thing that there's still debate about, it's often thought that, again, they don't care about being alone, right? And there's that symptom, neither desires nor enjoys close relationships. But some researchers, anecdotally, have reported, kind of like clinically, not documenting large studies of people, because not a lot of people to study, have said that they've talked to these people enough, gotten enough close enough to them, that they find out that the person is painfully alone, right? Desires a relationship, but is unable to do anything about it. Right? And so either these people were misdiagnosed and not really schizoid, or we don't really understand the schizoid personality disorder. Okay. Okay. So I think we can understand these three cluster A disorders a little better if we start looking at their relation to other disorders. So paranoid personality disorder and schizotypal personality disorder strongly related to schizophrenia. They're thought to be on the schizophrenia spectrum. They're schizotypic disorders, right? With this idea being that, and largely because of the idea that schizophrenia is largely influenced by genetics. For a long time, I thought one gene, which probably not, or they would have found it by now, but some combination of genes, but has a very strong genetic component. And people that, if we find a patient who has schizophrenia, their first-degree relatives are more likely to have paranoid personality disorder and or schizotypal personality disorder than someone in the general population. If we find a client who has paranoid PD or schizotypal PD, their first-degree relative is more likely to have schizophrenia than someone in the general population, which suggests that there's probably whatever that genetic vulnerability is to schizophrenia, it's similar to the genetic vulnerability for paranoid and schizotypal personality disorders. And the way the symptoms cluster together is similar in the personality disorders and in schizophrenia, with most people thinking that the personality disorders are basically an attenuated version of this schizophrenia vulnerability. So it's not as bad. You didn't get as much of whatever that genetic vulnerability was, to where you have these kind of full-blown delusions and hallucinations or disorganized thought. Right? And so it makes sense that they're in the same cluster together. And for a while, I thought schizoid was too, hence the the name. But more recently, they figured out, well, no, not really. People with schizoid personality disorder don't seem to be genetic related to people with schizophrenia, and it doesn't seem to work the same. And they don't have those other kind of key aspects associated with schizophrenic spectrum disorders. So paranoid and schizotypal go together, and they kind of cluster with schizophrenia. But again, they're personality disorders. And notably, though, most folks with paranoid PD and schizotypal PD, even though it's kind of it seems like a lesser version of schizophrenia, it doesn't seem to be a pre-morbid version. They don't go on to develop schizophrenia. Some do change diagnosis, but most continue to have these personality disorders without ever experiencing a full psychotic episode and being diagnosed with schizophrenia. Okay. So it's related, but different, not just an early version, but a lesser version. Now, schizoid personality disorder seems to be different than those, but it seems to be very similar to another personality disorder, which we'll talk about later, which is avoidant personality disorder. An avoidant personality disorder is characterized by a pervasive pattern of social inhibition, feelings of inadequacy, and a hypersensitivity to negative evaluation. And in the DSM, you distinguish between the two by saying, okay, well, neither one are in close relationships. They don't have, they don't have close confidants other than first degree relatives. Right? They tend to choose solitary activities. And the DSM, we look at it and you go, okay, well, the difference clearly, the avoidant, they're hypersensitive to negative evaluation. They're worried about being criticized, and that's why they avoid intimacy. In schizoid, they don't care. They're indifferent to praise or criticism. So there's the difference. And schizoid seems maybe kind of this worse version because they don't care. And avoidant, they want to be, but they're just so afraid. But it's not clear that this indifference to praise or criticism is true for people with schizoid. Some researchers suggested that indifference is surface level only. That you ask them, yeah, I don't care. People are of no significance to me. Does not matter. I prefer to be alone. But if you can get close enough to them, spend enough time with them, that they will eventually report beneath that surface level of indifference are deep fears and anxieties about being rejected. And so it looks very much like avoidant personality disorder. And some people have argued that these are the same disorder. It's just some people have gotten to a point where they hide their anxiety and fear and feelings of inadequacy, and other people don't. That otherwise, it's the same disorder. But the debate goes on. Okay. So schizoid may fit more with avoidant, which would put it more, excuse me, with kind of anxiety-related personality disorders in cluster C. But one thing that is at least getting, excuse me, increasing acceptance is that it doesn't appear to go with kind of the schizotypic, schizophrenic spectrum personality disorders. Okay, that's all for now. Take care.